Hello, good morning. This is the second of the two series of lectures that I'm now undertaking by way of this PowerPoint presentation relating to inflammatory bowel disease. The first is already recorded, entitled ulcerative colitis, and the basic information of inflammatory bowel disease is in that presentation. And I would be grateful if you could look at that presentation first. Having said that, there are some peculiarities of inflammatory bowel disease when Crohn's disease is concerned. So on the presumption that you may not have had a chance to look at the ulcerative colitis presentation, I will begin again afresh about my presentation on Crohn's disease. The knowledge has been updated in respect of the review made by NICE in respect of inflammatory bowel disease. So how does one describe Crohn's disease? It is obviously a gastrointestinal disease of an inflammatory nature, which is non-infectious and is characterized by chronic relapses and remissions. And it could occur in any part of the GI tract, starting from the oral region to the anorectum. It can occur in various segments with normal bowel in between, and therefore there would be skipped lesions, which is a characteristic difference between Crohn's disease and ulcerative colitis. The other main difference is that Crohn's disease involves the full thickness of the intestinal wall. So that means mucosa, submucosa, muscularis mucosa, muscles, and serosa. All of these are involved or can be involved with Crohn's disease. One of the basic things to remember in terms of management is the impact of Crohn's disease on the patients with both GI tract as well as extra-intestinal manifestations, and we'll cover grounds on these in a little while. So what is the pathology of Crohn's disease? As I've mentioned earlier, that it involves the full thickness of the intestinal wall. It could be diffuse, patchy, or continuous, but it is in its character that it would involve a segment of the bowel, large or small, and then it would end, followed by a healthy bowel on either side, and there may be a similar lesion elsewhere, proximally or distally. The pathology, as we will look into in a minute, the features are sometimes very similar to the features of ulcerative colitis, which is basically a mucosal lesions. And in 15% of cases that the pathologist sees, he finds no difference between the Crohn's disease and ulcerative colitis. The material for histology comes from upper GI tract endoscopy or colonoscopy. And it is customary for the endoscopist to take numerous target and random samples, usually numbering 5. And the endoscopy specialist would have noticed that there would be macroscopic inflammation involving the whole wall or some of the walls, which result in chronic cases with strictures. If the Crohn's disease involves the colon, then there could be some features of crypt distortion, cryptitis, crypt abscesses, and inflammatory changes. In children, it is often seen in 10 to 34% that the new onset Crohn's disease does not have typical features of chronic colitis on presentation, but develops it subsequently. The endoscopic feature from within the lumen would show with the bright light normal vascular texture, which is embedded in the submucosa and also is visible from the lumen of the bowel with magnification. Here, there is no ulceration, there is no erythema, and there is hardly any inflammatory change. A progression from here in the same patient would show thickening, inflammation of the mucosa. The thickness of the wall in this view shows up with this fold. And of course, there are patchy redness like here, here, and there. So these are inflammatory changes on the surface. And the lumen with this concentric whorl, which is thickened folds, appears to reduce the lumen. A stage further would show friability, and that is characterized by touching the mucosal surface with a suction or any other forceps, and it would start to bleed. So this friability associated with inflammatory, acute inflammatory changes is often characteristic of pre-ulceration. And of course, there would be thickening of the intestinal wall on the whole. If further progression will show moderate narrowing, there would be ulcerations as is characterized by these white spots. There would be presence of pus, and there will be denudation, loss of epithelium, loss of mucosa. And so therefore there will be bare patches as well. So these are features that you would see in various stages of relapsed Crohn's disease. And if you look at the histology further, you will notice that the inflammatory mucosa becomes spaced out. So this is normal colon with lots of cells, mucosal cells, and here they are spaced out, they are expanded, they are thickened, and whereas they dip down into a crypt lined by goblet cells, in the case of an active inflammation of, say, ulcerative colitis or Crohn's colitis, they would be distorted and the goblet cells would be missing. And if it becomes detached from the mucosa itself, then this would be a crypt abscess. So going on further, it is easy to see that the Crohn's disease can be characterized not just by histology, but also by virtue of its other behavior. So there could be regional involvement, such as in the ileum, such as in the junction between ileum and cecum, between the transverse colon or the whole of the colon, and there would be involvement of the rectum, which is rare relatively with Crohn's disease and much more common with ulcerative colitis. And we must always remember that both ulcerative colitis and Crohn's disease are parts of inflammatory bowel disease, and that common features occur in 15% cases histologically and 25% cases in terms of clinical findings. So by its location, Crohn's disease can be classified as Crohn's ileitis, Crohn's ileocolitis, and so on. So talking about the prevalence, it is virtually difficult to come to an exact number of prevalence. The reason is that different countries have different diagnostic criteria for diagnosis of Crohn's disease. And if the diagnosis cannot be made equally in various countries, then the prevalence rate would not be calculable. In the UK, the Office of the National Statistics in the period between 1950 and 1980, which is several years ago, calculated that 83 patients out of a million would suffer from Crohn's disease. An average single-handed GP practice is said to be around 1,200 to 2,000 patients on the list, and this would have 4 patients. But of course, increasingly, there are no single-handed practices anymore. So the group practices will have patient registration population around maybe 6,000 or more. 20 to 30% cases occur in patients under 20 years of age with equal predilection between men and women, but no age is immune. So what would be the complications of Crohn's disease? Ordinarily, one would think of pathological complications, surgical complications, and so on. But one of the greatest impacts which Crohn's disease has, and this is in common with ulcerative colitis as well, is psychosocial impact. Imagine a child going to school, not being able to attend physical sports or run around, play games during the school times, and in fact not be able to sit out a 1-hour presentation or teaching by a teacher because he's got to excuse himself to go to the toilet due to fecal urgency and other fecal symptoms. It is considered unsocial, unfortunately, for someone to absent themselves to be able to go to the toilet to open their bowels, particularly at school and at work or during leisure activities such as attending gym, going to the swimming pools, or in fact undertaking any lifestyle related physical exercise in a group setting. The impact of colostomy or ileostomy, the impact of having to live with changed diet, and also having to work in certain trades and not to work in certain trades will have a huge psychosocial impact, burdening income, quality of life, and so on. And this is why the quality of life indicators are important to use as far as the effect of the complications of Crohn's disease on the human body are concerned. Having said that, the common complications would include intestinal stricture. And so this is because of acute becoming chronic inflammation leading to thickening of the wall and then reducing of the lumen and gradually causing features of some obstruction, mechanical obstruction. In ulcerative colitis, there would be a segment which would swell up, flare up, and balloon up, but there would be no obstruction. And in Crohn's disease, there is obstruction, mainly because of stricture and leakage into various other viscera. However, the rule of thumb is that if you find an intestinal stricture in a patient during endoscopy, you must presume it to have been caused by cancer and therefore search it out. So fistulae into other loops of intestine, bladder, vaginal wall, vault, abdominal wall will lead to leakages and their own local visceral symptoms. Sometimes it becomes a sinus and erodes and discharges into the perianal region. On some occasions, the intestinal strictures lead to actual mechanical obstruction, leading on to dilatation, perforation, and hemorrhages. Whilst all of this is going on, obviously the absorptive capacity of the small intestine is considerably compromised, leading to malabsorption features. It is noticed that when someone has Crohn's disease, there is a higher incidence of bowel cancer. That is not to say that either Crohn's or ulcerative colitis are precancerous, because they are not. But the features which trigger inflammatory bowel disease are sometimes common to those triggers which cause cancer. And this is why either the detection rate of cancer is higher in patients with inflammatory bowel disease because of endoscopy, pathology, and so on, or there is a real increase in the incidence of bowel cancer when someone has a confirmed diagnosis of Crohn's disease or ulcerative colitis. We have already mentioned about bowel obstruction and bowel perforation, and this would lead to numerous issues, as it would in both ulcerative colitis and Crohn's disease. Attempted endoscopy can be invasive and dangerous, can lead to perforation equally if the endoscopy hasn't been done and the diagnosis has been inappropriately delayed and treatment has not begun. Then there would be a greater chance of bowel perforation in Crohn's disease as well. Fistula will cause their own individual visceral complications, as we have just discussed. The other issues with Crohn's disease is that of malabsorption, which could produce anemia of various kinds, and the malnutrition will affect a child's growth. And as we mentioned earlier, that even though neither of the two inflammatory bowel diseases are precancerous, incidence of independent bowel cancer is higher. Pouchitis is a new term used. I don't know why, but when someone has a colectomy, they would have an ileostomy for drainage. Similarly, in Crohn's disease, if the fistula has caused problems, say with the rectum needs to be removed. And if that is the case, then an ileal loop can be formed to act as a storage compartment, and that this would eventually drain off into a bag, and the ileal loop, which is the pouch into which the bowel drainage takes place, can often become inflamed or infected. So what would be the extraintestinal manifestations? Such manifestations are much more common with Crohn's disease preceding the GIT symptoms. And so non-weight bearing, vague arthritis affecting joints such as ankles, knees, hips, wrists, elbows, and shoulders in an asymmetric manner, distinguishing it from rheumatoid arthritis of an acute nature and self-limiting nature, lasting for weeks but leaving behind no permanent damage on the articular surface. Sometimes this involves that part of the tendon which is attached to the bone, and that's called enthesitis, or the whole thickness of the tendon, such as quadriceps or Achilles, can be involved with the process of inflammation. Tenosynovitis, or the entire finger might be involved. Erythema nodosum, which occurs more often with ulcerative colitis than with Crohn's colitis, is a subcutaneous lump of a slightly dark sort of nature. Immune-related conditions such as aphthous ulcers are also common. So if you look at the anterior surface of the legs, you will see these dark spots, and they are raised above the surface and can be palpable. that is erythema nodosum. Involvement of the eye is also common, and obviously it is a recognized complication of Crohn's disease. And we'll look at a picture. Pyoderma gangrenosum is also another feature. And polyarticular arthritis, such as sacroiliitis, venous thromboembolism, which carries a risk twofold higher than with ulcerative colitis, are also features of extraintestinal problems of Crohn's disease. And you can see the redness, which is characterized in this segment, but it is not visible on the lids and possibly not on the conjunctiva either. And you can see the pustular lesion with necrosis at the border, and in the same patient, a large part of the dead tissue has already been excised. So that would have been the gangrene part of it. And this can lead on neglect to pregangrene and gangrene. So what would be the risk factors attached to Crohn's disease? One knows that with biological parents having had inflammatory bowel disease, the risk of offsprings is in the region of 25 to 40% in getting Crohn's disease. Some infectious gastrointestinal lesions, such as those caused by Clostridium difficile, can precipitate a latent condition of Crohn's disease. The position of appendicectomy is different between ulcerative colitis and Crohn's disease. So if appendicectomy has been done for the right reasons earlier in life, then there is a greater risk of developing Crohn's disease. And in ulcerative colitis, appendicectomy confers protection. Same situation appears in smoking. Nicotine consumption by whichever manner increases the risk of Crohn's disease into having another relapse. And smoking appears to be protective in some ways in ulcerative colitis. Common to both conditions, irritant medications, thrombogenic medications will also add risks to extra intestinal complications of Crohn's disease. So where are we with regard to prognosis? So it's a condition which is known to exist lifelong with relapses and remission. And the all-cause mortality is higher by 1.38 times. Ileitis and ileocolitis are more stable than other regions which have got Crohn's disease. 10% people have prolonged remission, 30% have strictures in Crohn's disease, 50% people in the meta-analysis have undergone surgery but had recurrence after 10 years. The factors which would suggest poor prognosis are early age of onset, presence of perianal disease, and use of corticosteroids on presentation. So the diagnosis can actually be made on the basis of symptoms. Remembering that Crohn's disease may appear insidiously and vary in presentation. It could cause persistent diarrhea over 4 to 6 weeks, mainly nocturnal. It could have bloody diarrhea for more than 6 weeks, which is Crohn's colitis. With Crohn's colitis, there is a greater incidence of anorectal incontinence or nocturnal diarrhea. Tenesmus is pain in the attempt of defecation with there being no stool in the rectum. And it also causes urgency. Abdominal pain in the left iliac fossa is also a common symptom. If there is concurrent urinary tract infection, one would need to investigate whether the pre-existing Crohn's disease has now involved the urinary bladder. There are non-specific symptoms with Crohn's disease, such as those of malabsorption, chronic illness, post-viral condition, and so on. In terms of physical signs, there may not be a physical sign in the early stage. There would be features of anemia or immune reduction characterized by opportunistic infections. There would be distension of abdomen with tenderness or mass in the left iliac fossa, representing the full thickness involvement of Crohn's colitis. There could be extra-intestinal signs, as we have discussed as well. So, what investigations are usually ordered in the NHS primary care? It's full blood count, remembering that isolated increase of platelet count is now regarded as an inflammatory marker. Anemia, ferritin or iron, B12, folate, and vitamin B12 will show absorptive disorders in various parts of the gastrointestinal tract. Urea and electrolyte, which would represent dehydration and also concurrent involvement of the bladder and also absorption problems in relation to fluids. C-reactive protein and erythrocyte sedimentation rate are commonly done as inflammatory markers in a relapse. They are good measures of seeing the progress to worsening or improvement. Liver function tests, including albumin, amylase, and tests for albumin should be done. Thyroid function tests should be done for completion's sake, as hyperthyroidism can produce the accelerated rate of bowel emptying. Celiac serology should be done to see whether there is intolerance to wheat or to other aspects of food. The stool microscopy needs to be cultured for Clostridium difficile toxin. Fecal calprotectin is a very important test which must be done in inflammatory bowel disease, and this is a white cell marker for adults. Amylase for pancreatitis, tests for inflammatory arthritis such as rheumatoid arthritis, anti-CCP antibodies, and so on should be done as well. Abdominal ultrasound scan can show up strictures, megacolon, or fistula. So the differential diagnosis is with a large range of bowel conditions, including ulcerative colitis, infective colitis, ischemic colitis, and in ischemic colitis, there would be pain out of proportion to visible pathology, diverticulitis, microscopic colitis, and IBS. Another emerging factor is laxative misuse. So it's traditional when people have low fiber diet, as is not uncommon in the UK, that there would be constipation. And as such, people would be resorting to laxatives. The osmotic laxatives such as lactulose, and movicol are safer, but require a lot of water to form a gel for facilitation of bowel action. And when one is using irritant laxatives or purgatives all of the time, such as Dulcolex and so on, it would induce a condition where there would be increased diarrhea, increased frequency, and abdominal pains. So how does one manage in the hospital in the UK under the NHS? So when in the primary care patient has presented with a condition which is unmanageable at home, then obviously they are referred to the accident and emergency or booked in direct with the gastroenterologist into the ward of the hospital, but routed via casualty. So resuscitating measures would need to be applied. And the usual tests include blood tests, CCG, urine, stool, and of course, there would be assessment of cardiorespiratory condition. Pain relief would be provided by appropriate analgesia, and we'll touch on the subject of pain relief and antidiarrheals in a minute. If it is considered safe, colonoscopy, otherwise CT colonography, and of course, magnetic resonance enterography can be done quickly after ultrasound scan of the abdomen. In relevant cases, upper GI tract endoscopy, pelvic MRI, or CT scans can be done to delineate the pathology. And of course, on the ward, detailed assessment followed by investigations for extra-intestinal complications would need to be done. If there is a patient who has been diagnosed with Crohn's disease and then presents in the primary care on a follow-up, how does one assess his suffering or his improvement? We need to assess the impact on his daily functioning and cater for anxiety and depression and psychosocial aspects. We need to provide advice on management of Crohn's disease by the patient themselves. And so we would need to offer them these signposting via internet, by phone calls, or through booklets or literature. Healthy lifestyle is promoted with or without contribution from the dietitian. In the UK, a big national charity called Crohn's and Colitis UK offers advice and support to patients and their families. Another pediatric-based Great Ormond Street originated charity is called Crohn's in Childhood Research Association. And they deal with children, parents, families. One would need to assess the risk of osteoporosis from the point of view of malabsorption produced by Crohn's disease, but also from the treatment that is used for the Crohn's disease management. Because it's a lifelong condition, in the primary care, it is ascertained that the patient has follow-up appointment in the hospital, appropriate monitoring before that appointment, and that this is a lifelong condition. And the commonest contact a patient in remission has with the hospital is through the colorectal nurse specialist. And of course, it is equally important to maintain colorectal cancer surveillance, which in the UK is undertaken through fecal occult blood testing in all elderly adults, males and females. So if there is positive fecal occult blood present, then automatically the system would arrange for a colonoscopy so that any inherent cause could be identified. The treatment is often begun in the secondary care, and in the primary care, the treatment and its monitoring are maintained. And the monitoring would involve levels of iron, B12, folate, calcium, vitamin D, and of course, supplementation of deficiencies. Colorectal surgeon may be needed for advice and follow-up if there are post-operative complications or if there are rectal issues such as fistula, fissures, and also sinuses. Colorectal nurse specialists will team up with the stoma nurse and advise particular advice on ileostomy and on pouches made as reservoirs. Patients, because of their inflammatory bowel implications and for the treatment, are immunocompromised and are supported and encouraged to have non-live vaccinations such as influenza and pneumococcal vaccine. So what is the specialist treatment of Crohn's disease? It is of a few agents. Aminosalicylates, the common one is mesalazine and sulfasalazine, which can't be used in sulfonamide allergic patients, but it is one of the mainstay treatment of Crohn's disease. It is quite effective in maintaining remission and it can be prescribed orally, topically, as suppository, or as enema. If remission is not achieved within 4 weeks, other treatment are started. And the other treatment would be corticosteroid monotherapy, such as prednisone, foam, enema, and so on. And this can produce a remission, but it does not form part of maintenance therapy because of its inherent dangers with regard to osteoporosis, gastric ulcer, adrenal shutdown, and postural hypotension, and so on and so forth. Immunosuppressive drugs such as thiopurines are often used as well. So azathioprine, mercaptopurine, or cyclosporine. Methotrexate can also be used, but these are second line, and methotrexate in particular in Crohn's disease can increase the risk of melanoma. Biological treatment with anti-tissue necrosis factor alpha monoclonal antibodies can be given parenterally. Infliximab by infusion, Humira as subcutaneous, or golimumab as both infusion as well as subcutaneously can lead to reliable remission in most patients. But these are offered when conventional treatment, which I've just discussed earlier, have failed or are ineffective. Sometimes specialist enteral nutritional support might be all that is needed to achieve a remission, and therefore that would be a very good thing. So in the primary care, if there are flare-ups, one arranges emergency admission and one assesses the disease severity assessment. The clinical features of diarrhea, nocturnal diarrhea, bloody diarrhea are also controlled in the primary care. Signs of malnutrition are noted and improved on. Inflammatory markers and other aspects of assessment are checked. Compliance to medication is checked. And also, it is important to avoid prescribing anti-inflammatories and the referral to the dietitian expert in inflammatory bowel disease should be made for a follow-up. If a patient appears to have diarrhea, one should exclude other causes such as abscesses, dysmotility, and so on and so forth. Sometimes these are the side effects of treatment also. Anti-motility medications such as loperamide and hyoscine should not be prescribed, as the incidence of toxic megacolon in ulcerative colitis is high, and also of intestinal obstruction is high in Crohn's disease. For constipation, a bulk-forming laxative such as isfagula husk or methyl cellulase or istraculia are all that are needed to improve and control diarrhea and constipation. For abdominal pains, opioids should not be used, as they would cause masking of symptoms and also maybe worsening the conditions such as hypotension from loss of fluids. Paracetamol is usually advised, but not non-steroidal anti-inflammatory disease. For fistula and stricture, if these are asymptomatic, no treatment is needed. Otherwise, simply advice of the colorectal nurse specialist on management of fistula or colostomy or ileostomy is usually good enough. But often these conditions get infected mainly with gram-negative bacteria, and so gram-negative antibiotics such as metronidazole or ciprofloxacin are generally used. For vague problems such as fatigue and oral problems, one must obviously look out for a pathological reason such as anemia, malnutrition conditions, and also sleep deprivation, stress, and anxiety. If there are oral issues, then a referral to the dentist or maxillofacial specialist would be required. There are issues in respect of contraception. And because of the dangers of the treatment producing venous thromboembolism and osteoporosis, it is important to apply UK medical eligibility criteria to consider which oral contraceptive or other forms of contraception should be advised. If a person is of a fertile age and is on methotrexate, a 3-month abstention from methotrexate is needed before oral contraception can be prescribed. And with anti-TNF, there should be a 6-month abstention. Fertility advice is something that can be provided by an obstetrician who is expert in inflammatory bowel disease as well. And each region has at least 1 or 2 such specialists. So this is how one classifies the impact on the patients on the basis of stool frequency, rectal bleeding, findings seen on sigmoidoscopy or colonoscopy, and the global assessment of the physician. So if the stool frequency rate is normal, which is once a day, then it's a normal number, so the score is 0. 1 to 2 stools per day would be more than normal, and so that would be scoring as 1. 3 to 4 stools per day, score 2. 5 or more stools per day, then score 3. And so you've got a score of 3 on the basis of stool frequency. With rectal bleeding, similarly, there's a score. So it is said that a score above 4 overall will lead to a significant impact on the patient's life. So you can assess how one person differs from another in respect of Crohn's disease. And this is characterized by IBD endoscopic index as well, but this is much more reliable. I hope that this presentation, though rapidly given, has made some sense to you, and that you would be able to deal with patients suffering from inflammatory bowel disease more reliably. Do look up at the presentation on ulcerative colitis. Thank you very much for taking the trouble to listen to this presentation. Thank you.